Intracranial tumors. Brain tumors. Primary brain tumors occur in 6 persons per 100,000 per year. In adults, 80 to 85% of the brain tumors localized in supratentorial region. 15 to 20% of the brain tumors localized in infratentorial region. Presentation: progressive neurologic deficit, 68%. Headache, 54%. Seizures, 26%. Presentation of supratentorial tumors: increased ICP, progressive focal deficits, headache, seizures, mental status changes, symptoms suggestive of a TIA or stroke, endocrine disturbances. Presentation of posterior fossa tumors: increased ICP due to hydrocephalus. These include headache, nausea/vomiting, papilledema, ataxia, vertigo, diplopia. Lesions in cerebellum may cause ataxia, dysmetria, and intention tremor. Brainstem involvement usually results in multiple cranial nerve and long tract abnormalities. WHO classification of SNES tumors, 2007. 1 tumors of neuroepithelial tissue. 2 tumors of cranial and paraspinal nerves. 3 tumors of meninges. 4 lymphomas and hematopoietic neoplasms. 5 germ cell tumors. 6 tumors of the cell region. 7 metastatic tumors. 1 tumors of neuroepithelial tissue. 1.1 astrocytic tumors. Pilocytic astrocytoma, grade I. Diffuse astrocytoma, grade 2. Anaplastic astrocytoma, grade 3. Glioblastoma, grade 4. 1.2. Oligodendroglial tumors. Oligodendroglioma, grade 2. Anaplastic oligodendroglioma, grade 3. 1.4. Ependymal tumors. Ependymoma, grade 2. 1 tumors of neuroepithelial tissue. 1.5 choroid plexus tumors. Choroid plexus papilloma, grade I. 1.8. Pineal parenchymal tumors. Pineocytoma, grade I. Pineoblastoma, grade 4. 1.9. Embryonal tumors. Medulloblastoma, grade 4. 1.1 astrocytic tumors, most common primary intraaxial brain tumors. Pilocytic astrocytoma, grade I. Slow-growing benign tumor. Location: optic gliomas and hypothalamic gliomas. Brainstem gliomas. Cerebellum. Spinal cord. Treatment of choice is surgical excision. 1.1 astrocytic tumors. Diffuse astrocytoma, grade 2. Tend to occur in children and young adults. Demonstrate low degrees of cellularity and preservation of normal brain elements within the tumor. Surgery is the principal treatment. Radiation is not indicated. 1.1 astrocytic tumors. Anaplastic astrocytoma, grade 3. Occur in patients who are generally a decade older than those with an astrocytoma but a decade younger than those with a glioblastoma. Duration of symptoms is usually shorter than that for the former lesion and longer than that for the latter. Surgery followed by radiotherapy has become the standard. Reoperation for recurrence extends survival. 1.1 astrocytic tumors. Glioblastoma, grade 4. The commonest primary brain tumor. It is also the most malignant of astrocytic tumors. It occurs most common in the cerebral hemisphere in the 5th decade or above. The symptoms of glioblastoma are usually of recent onset, and the patient is more ill. It has characteristic ring of contrast enhancement surrounds a center of low density, and has a zone of low density or edema around the ring enhancement. Untreated glioblastomas is one of rapid progression. Radical surgery followed by radiotherapy plus chemotherapy is recommended. Reoperation for recurrence extends survival. 1.2. Oligodendroglial tumors. Oligodendroglioma, grade 2. Frequently presents with seizures. Often calcified, predilection for the frontal lobes. Comprises 4% of primary brain tumor. Aggressive removal leads to longer survival. anaplastic oligodendroglioma, grade 3. Surgery followed by chemotherapy is recommended. 1.4. Ependymal tumors, ependymoma, grade 2. 5 to 6% of intracranial gliomas, mostly occurs in children. Usually well circumscribed and benign, commonly arises in the floor of the fourth ventricle. Comprises 25% of tumors in region of fourth ventricles. Has potential to spread through CSF to spinal cord, a process known as seeding. Mostly those of posterior fossa mass with increased ICP, headache, nausea and vomiting, ataxia or vertigo. Goal of surgery is maximal possible resection without causing neurological deficits. Total surgical resection followed by craniospinal radiotherapy is recommended. 1.5 Choroid plexus tumors, choroid plexus papilloma, grade I. 0.4 to 1% of all intracranial tumors. Most of patients are less than 2 years old. It is histologically benign tumor. May become symptomatic because of the increased ICP produced by secretion of CSF. May be cured surgically with total removal. 1.7 Neuronal and mixed neuronal glial tumors. Paraganglioma, chemodectoma, glomus tumors. Histologically benign and slow-growing tumors. Arises from paraganglion cells, usually in the area of the jugular bulb, and tracks along vessels. A very vascular tumor with main feeders from echo. Patients commonly present with hearing loss and pulsatile tinnitus. Combinations of palsies of cranial nerves 9, 10, 11 and 12 occur with occasional 7 palsy. Radical surgical removal is recommended. 1.8. Pineal parenchymal tumors. Pineocytoma, grade I. A well-differentiated neoplasm arising from pineal epithelium. It can metastasize through the CSF and is radiosensitive. Pineoblastoma, grade 4. A malignant neoplasm arising from pineal epithelium. It can metastasize through the CSF, and is radiosensitive. 1.9. Embryonal tumors, medulloblastoma, grade 4. 15 to 20% of intracranial tumors in children, and is the most common malignant pediatric brain tumor. Usually arises in the cerebellar vermis and predisposes to early obstructive hydrocephalus. Usual presenting symptoms, headache, nausea and vomiting, ataxia. Usually appears as a solid, midline, and for contrast enhancing lesion on MRI. May disseminate via the CSF spontaneously or iatrogenically following surgery. Prophylactic craniospinal radiotherapy is indicated following surgical removal. In children, radiotherapy causes intellectual impairment and growth retardation and is avoided before 3 years of age. 2 Tumors of cranial and paraspinal nerves. 2.1 Schwannoma, neuronoma, grade I. Slow-growing, benign tumor. Most arise from superior vestibular division of 8th nerve. 8 to 10% of intracranial tumors. Incidence is 1 case per 100.000 population. 95% are unilateral. Bilateral tumors being pathognomonic of NF2. The incidence of ursus is increased in NF2. Most common early symptoms are unilateral progressive hearing loss and tinnitus. Otalgia, facial numbness and weakness, and taste changes occur as the tumor enlarges. Larger tumors cause brainstem compression with ataxia, nausea and vomiting, diplopia, cerebellar signs, and lower cranial nerve palsies. 2 Tumors of cranial and paraspinal nerves. 2.1 Schwannoma, neuronoma, grade I. MRI is the diagnostic procedure of choice. Round or oval enhancing tumor centered on internal acoustic meters. All patients should have the detailed audiologic exam. Total surgical excision is the treatment of choice for most tumors. For small tumors follow symptoms, hearing, and tumor size by serial MRI. Intervention is recommended if growth greater than 2 mm/year. Total excision of tumor is the goal of surgery. Facial nerve is pushed forward by the tumor and preservation of the facial nerve is very important. Facial reanimation, hypoglossal facial anastomosis, is performed after 1 to 2 months if 7 was divided, or if no function returns after 1 year with an anatomically intact nerve. 3 tumors of the meninges. 3.1 Tumors of meningothelial cells. Meningiomas. 15% of primary intracranial tumors. Slow-growing, extra-axial circumscribed, usually benign tumors, which arise from arachnoid, not dower. Frequently calcified and often cause hyperostosis of adjacent bone. Usually cured if completely removed. Most commonly located along the parasagittal and fall, convexity, or sphenoid bone, however may occur anywhere that arachnoid cells are found. They can be asymptomatic. May be multiple in some of cases. This finding is more common in neurofibromatosis. 3 tumors of the meninges. 3.1 Tumors of meningothelial cells. Meningiomas. Big incidence at 45 years age, rarely occur in childhood and adolescence. Occur with a higher incidence among women than among men. Parasagittal and fall meningiomas up to half invade the superior sagittal sinus. Plain X-rays may show calcifications within the tumor, in 10%, hyperostosis of the skull, enlargement of vascular grooves, especially middle meningeal artery. MRI, appear as homogeneous, densely enhancing mass with broad base of attachment along dural border and dural tail is a common finding. 3 tumors of the meninges. 3.1 Tumors of meningothelial cells. Meningiomas. Characteristically, it has external carotid artery feeders in angiography. Angiography also gives information about occlusion of venous sinuses. Surgery is the treatment of choice for symptomatic meningiomas. Incidental meningiomas may be managed expectantly with serial imaging, as meningiomas tend to grow slowly. Extent of surgical tumor removal is the most important factor in the prevention of recurrence. Radiotherapy reserved for malignant, invasive, aggressive, or non-resectable meningiomas. 3 tumors of the meninges. 3.4 or other neoplasms related to meninges. Hemangioblastoma. It represents 1 to 2.5% of intracranial tumors. The most common primary intraaxial tumor in the adult posterior fossa. 20% occur as part of von Lippel-Lindau disease. It is histologically benign tumor. Mostly cystic with a mural nodule. Nodules are very vascular. Surgical treatment may be curative. For lymphomas and hematopoietic neoplasms. 4.1. Malignant lymphomas. Occur at any age. Most frequently arise in the cerebral hemispheres, where, as contrast-enhancing masses. Lesions usually enhance homogeneously without the typical ring of the glioblastoma. SNES involvement with lymphoma may occur secondarily from systemic lymphoma, or may arise primarily in the SNES. 10 to 30% of patients has multiple lesions. There is an almost diagnostic tendency of rapid partial to complete resolution on MRI following the administration of steroids, producing the so-called ghost tumor. The standard treatment after tissue biopsy is steroid therapy, chemotherapy and whole brain radiation therapy. With no treatment, median survival is 2 to 3 months following diagnosis. 80% of cases recur, usually 15 months after treatment. 5 germ cell tumors. Occur principally in the pineal and supracell regions. Almost all patients have hydrocephalus by the time of presentation. Aside from benign teratoma, all intracranial GCTs are malignant and may metastasize via CSF and systemically. Characteristically, but not always, give rise to tumor markers, SSHCG and AFP, in the CSF. Germinomas are malignant tumors of primitive germ cells that occur in the gonads or in the SNES. Survival with these is much better than with non-germinomas, embryonal carcinoma, choriocarcinoma, teratoma. Some of the germinomas are potentially curable with radiation therapy, but this is less likely for the other lesions, particularly the teratocarcinoma and choriocarcinoma. 6 tumors of the cell region. 6.1 Craniopharyngioma. Benign tumors but difficulty in cure makes them malignant in behavior. 2.5 to 4% of all brain tumors tend to arise from the pituitary stalk. Almost all CP have solid and cystic components and calcification is very common. Surgical approaches usually via terminal, or combined, transcallosal and terminal. Diabetes insipidus often develops postoperatively. Postoperative mortality is 5 to 10% in most series, most from hypothalamic injury. Post-op radiation probably helps prevent regrowth when residual tumor is left behind. However, in pediatric cases it may be best to postpone radiotherapy, recognizing that reoperation may be necessary for recurrence. Morbidity/mortality is higher with reoperation. 7. Metastatic tumors. Most common sources of cerebral mets in adults are lung, breast, kidney. Small cell Ca of the lung is more likely to produce cerebral mets. The highest incidence of parenchymal mets is located on the territory of MCA. Solitary lesion in the posterior fossa of an adult is considered a metastasis until proven otherwise. Usually appear as well-circumscribed non-complicated masses on MRI. Usually enhance in MR, and must be considered in the differential diagnosis of a ring-enhancing lesion. With optimal treatment, median survival is only 32 weeks, therefore management is mostly palliative. 7. Metastatic tumors. Medical management with radiation therapy without surgery is recommended for patients with multiple cerebral metastases, or widespread systemic cancer and obviously short life expectancy. Initial treatment, anticonvulsants, corticosteroids. Excisional surgery for solitary lesions is indicated when lesion accessible, lesion is symptomatic or life-threatening, primary tumor known to be relatively radioresistant, or diagnosis unknown. Stereotactic biopsy may be considered for deep lesions, in patients who are poor surgical candidates, to ascertain a diagnosis when another diagnosis is possible, or for multiple small lesions. Radiation therapy is usually administered following surgery, where micrometastases are presumed to be present throughout brain. Pituitary adenoma arise primarily from the anterior part of the pituitary gland. Represent 10% of intracranial tumors. Most common in the 3rd and 4th decades of life, and equally affect both sexes. Usually present either due to endocrinologic disturbance, or due to mass effect. Divided into 2 groups, functional, secreting, and non-functional, non-secretory. Functional tumors frequently present earlier with symptoms caused by endocrinologic disturbances. Non-functional tumors usually do not present until of sufficient size to cause neurologic deficits by mass effect. Pituitary adenoma. Panhypopituitarism may be caused by large tumors of the non-functional type. In large tumors optic chiasm may compressed, classically resulting in bitemporal hemianopsia. In endocrinologic evaluation we have to check the adrenal axis, thyroid axis, gonadal axis, prolactin level, growth hormone, and neurohypophysis. Lateral skull X-ray may help define anatomy of sphenoid sinus in cases where transsphenoidal surgery is planned. MRI is choice for pituitary adenomas. Microadenoma, less than 1 cm, macroadenoma, greater than 1 cm, pituitary adenoma prolactinoma. Causes amenorrhea galactorrhea syndrome in females, impotence in males, and often infertility in either sex. If no acute progression, these tumors may shrink dramatically on bromocriptine, dopamine agonist. Surgery is indicated if PRL greater than 500 and tumor not controlled on bromocriptine. Surgery followed by reinstitution of bromocriptine therapy may normalize PRL. Pituitary adenoma acromegaly. GH-secreting tumors that cannot be managed medically. Causes acromegaly in adults, and gigantism in prepubertal children. If no contraindications, transsphenoidal surgery is the best initial therapy. For patients not cured by surgery, or with recurrences after surgery, radiosurgery is indicated. Pituitary adenoma Cushing's disease. Elevated ACT causes endogenous hypercortisolism, Cushing's disease. Long-term efficacy of medical therapy is inadequate. Surgery is recommended. Pituitary adenoma. Transsphenoidal approach usually the procedure of choice, an extra-arachnoid approach, no external scar, and no brain retraction. Transsphenoidal approach indicated for microadenomas, macroadenomas without significant extension laterally beyond the confines of the cella and tumors with extension into sphenoid sinus. Transcranial approaches, terminal, is useful for macroadenomas. Pituitary adenoma. Radiation therapy should not be routinely used following surgical removal of pituitary adenomas. Follow patient with yearly MRI. Treat recurrence with repeat operation. Consider radiosurgery if recurrence cannot be removed and mass continues to grow. Pituitary adenoma, pituitary apoplexy. Onset of neurologic deterioration usually consisting of headache, visual deficit, ophthalmoplegia, and reduced mental status. Usually due to an expanding mass within the cella turcica as a result of hemorrhage, necrosis, or infarction within the tumor. CT or MRI shows hemorrhagic mass in cella and/or suprasellar region. Emergency decompression to preserve vision is usually indicated. Chordoma. Chordoma. Benign, slow-growing, locally aggressive, and have a high recurrence rate. Red tumors of the remnant of the primitive notochord. May arise at end of the notochord in the spheno-occipital region, clevis. Radical surgical removal is recommended. Cysts and tumor-like lesions. Epidermoid cyst. Occur most frequently in the leptomeninges, especially those of the CPA and suprasellar region. Comprise 1% of intracranial tumors, and 7% of CPA tumors. Tend to spread along normal cleavage planes and surround vital structures. Surgery is the essential treatment method.